Good evening, guys. How are you?
Good evening. I'm well. How are you?
Doing good. I'm doing good.
How are you, Eduardo? Can you hear us?
Eduardo. You can't hear us. Oh, yeah.
Hello. Can you hear me?
Yes.
Yes. I can't hear you.
One second. Oh, he has Spanish. He has Spanish selected, and the interpreters are muted. Once the interpreter starts speaking, we will hear you all. Okay, so he's on the Spanish, and the interpreters haven't started to interpret because we haven't.
How do we change him to English?
We'd have to tell him to. Okay. English.
Hey, Bev. So I was looking at the slide. So I am introducing. I'm just giving a welcome to the webinar, and then
Yeah,
it looks like Dr. Rodriguez is moderating, or Dr.
Actually, Dr. Payette is moderating.
With us.
He can't hear us though because he's in the Spanish language, and they have not started with the interpretation. So we need to figure out how to get him out of there.
We're about to change him to English right now.
Okay.
It's always exciting.
We really pretty much have this down now.
Yeah. So when I do the introduction, then it automatically gets translated for the people who are listening in Spanish.
Correct.
And so where do you choose your language?
Down at the bottom of your screen where it says your language floor.
Uh-huh. Oh, I got you. So if I just clicked on Spanish, I could not understand the whole thing. Okay.
Unless you speak Spanish.
Okay. Hello, how are you? Good afternoon. Can you hear me?
Yes.
Finally. Thank you.
Sorry about that.
Bev, does it go to 6:30 or to 6?
I
think it starts at 6:30. 6:30 for you.
So it's an hour and a half.
Correct. Sorry, it had to do the time.
I just didn't know. I just wanted my question should have been: is it an hour or an hour and a half?
It's an hour and a half. And if you can't be on for the whole time, that's okay.
It's okay. Yeah.
Bev, can you hear me?
I can. How are you?
Fine.
Good.
Good afternoon, everybody, or good evening for some of us. How can I present how can I put the presentation?
Okay, if you just wait a second until we get all of our speakers on, Vernon will give us a little tutorial and let everybody know how it works.
Okay. Is everything okay, Taylor?
Yeah. Do I look like I'm concentrating, Ulysses? I've had like just a crazy day of like really weird results. And
my day was awful also.
I'm just like, I don't know where they find this stuff for me, but they do.
Daniel, can you hear us?
Then it's concentrated.
Hey, just quick note, Bev.
Good evening.
Some people have joined as speakers. Do you want us to have some of them in the audience, or is everyone who's joined as a speaker speaking?
I'm going to put them back in the audience when they're not speaking, but I wanted all the speakers to be on to hear the instructions.
Okay.
Actually, all the speakers are already here, right? The panelists are not, but...
Dr. Paredes, Oscar is not here yet. He's the first presenter.
I'm seeing him.
You do see him?
Yeah.
Yes.
Now he's frozen. On the...
Is Dr. Rodriguez on? I don't see him.
Yes.
Okay, just
maybe they have connected in Spanish. I mean, in this system you have to choose your language, and if we want to hear you, we must select English. Is that right?
That's correct, but I don't see him on the list at the moment.
Who? Oscar Paredes, he was here. And maybe, and Ramiro is here as well.
Good evening. Dr. Payet. I'm pleased to see you again. I'm not actually in Peru right now, so I apologize if I couldn't have joined earlier. However, it's a great pleasure to have you in this third webinar for the Peruvian chapter, and moderated with Dr. Payet, who is a leader in the field of gastric cancer in Peru. So it's an honor to have you all. Thank you, Beverly, for hosting this and helping so much. So, Dr. Ryan, once again, we want to welcome you as new president of the SSAT. So I'm very happy that the Peruvian public surgeon will meet you now. So without delay, I will leave you. So thank you. I'll be here all the session. So good evening.
Thank you. Thank you for doing this.
All right, Vernon, do you want to just give a quick overview? Can't hear you.
My apologies. I said absolutely. So good evening, guys. Welcome to our final interpretation session for the Society of Surgical Alimentary Tract. As I've introduced myself before, I'm just going to do it again. My name is Vernon Williams, CEO of Translingua. For those who are joining us for the first time, the floor language will be the initial language of the speaker. To change the language, the target language in which you guys are wanting to hear the interpreter is what you guys will select. So for example, if you want to hear me in Spanish, which you guys will go down to the bottom right corner of your screen and you'll hit Espanol. And once you hit Espanol, you will start to hear the interpreter simultaneously interpret what I'm saying from English to Spanish. Also, Ms. Bev Hendry will be the moderator. So she will be the one who will be making you guys the speaker. And once you become the speaker, you guys will have access to share your screens if you guys would like to present. So far, does anybody have any questions?
So what I would like to do, because there is a lot of people that are participating in this, is that when Dr. Real and Dr. Rodriguez do their welcomes, I'm going to take everybody off the main screen and put you in the audience. And then when it is Dr. Paredes' turn to present, I'll bring you back on. Because if there's too many pictures on the screen, then your slides are really small and the audience can't see them well. Does that make sense to everybody?
Also, the interpretation has begun. So you guys are ready to start at any time.
Okay, well, we actually don't start till 7.
Oh, right. Well, they've been interpreting. They've been practicing.
Okay.
Also, one last thing for the presenters, because the interpreters are speaking at the same time and doing the same interpretation, just allow yourself to speak at a very natural, slower, maybe than usual pace, and have natural pauses in between, different phrases, words, and sentences, and just be mindful that, the more natural, the slower the interpretation is, the more efficient and effective the interpretation will be. And also there is a group chat. If anybody has any questions, I'll be constantly monitoring the group chat. The group chat is in the top right corner. It has a little symbol with 3 lines, the middle line being the longest. Also, when you type in there, whether it's English or Spanish, and I'm typing in right now, you have the option to either send that to the general, which is everybody, or the speaker, or the moderator and the interpreter. You could also have private chats. For example, if I wanted to say something to Ms. Bev Hendry, I would just hit the private chat and I would just ask her a question. Also, when you send a chat, you have the option to also translate it. So feel free, like I said, to chat or type in any language you guys would like. And also, if you have any questions, like I said before, feel free to ask me at any time.
Yeah. Okay.
I'm sorry, I had to get out of the screen. How do I do my presentation?
So once it's time for your presentation, you'll be promoted to speaker. And then do you have your presentation on your screen?
Yes, I do.
Okay. So once you have access to your screen, you'll see a small icon on the right-hand side where you're going to be able to share your screen.
Now, who is asking? Ulysses?
Yes.
Okay, let me make you so you can test it.
Yes. Yeah.
Can I test it?
Hang on a second.
What you're looking for is the head icon once you get promoted.
I just already give the floor to Dr. Ulysses. So, Dr. Ulysses, you might find the share screen icon, which is located at the bottom of the screen, which is going to be like a screen icon, just exactly at the bottom. So once you click right in there, you will have the option to share your screen, and you'll have also 3 different options of sharing screen. Share the full screen or a specific application screen, or any of your browsers tab as an option as well.
Hey, Bev, are you gonna put up the intro slides, or did you want me to put those ones up that you sent me?
We can do it either way. Would you prefer I do it?
Maybe.
Okay.
Can you see it?
Yes.
Yes.
See it.
Yes. Right. Great. It's easy then. Thank you.
Okay. Can you hear me?
Yes.
Yeah.
Right. So my role. So we're going to have 3 talks, every 15 minutes each, and I'm going to be the moderator. Is that correct? Or are you going to do it, Henry? Oh,
No,
yeah.
you are the moderator. I am just the controller of the
Right.
screen.
Right. So I will be presenting the participants in each talk, and after the 15-minute talk, I will make the welcomes to the discussions and ask some questions. So I'll do it in Spanish. Is that okay with you?
Yes.
Because I believe the talk of Dr. Paredes is going to be in Spanish, and then we'll see how it goes, right? And my second question is, this has to be, all the session will take an hour, is that correct?
No, it's 90 minutes for the whole thing.
Okay, 90 minutes, right. Okay, thank you.
Hello for everyone. I can find the button to share my screen.
Okay,
Okay,
let me just give you the floor so you can have available the option to share screen. Just one
Yes,
moment.
because I will do the first. I will be the first speaker. So okay.
Oh,
Now
there it
I
is.
see. Yeah,
Excellent.
thanks.
Thank you.
So you only see that icon when I think you're set to speak, right?
Yes.
correct.
May I test also, please?
Yes, please.
Please also let us know if you have any questions if you have any question with the share screen option. We'll also going to guide you in case you need it. I'm also going to say it in Spanish. En caso de que también necesiten apoyo con o guía con lo que es con la opción de compartir pantalla, por favor también háganos saber y con muchísimo gusto los estaremos apoyando. Muchas gracias.
Vernon,
Okay,
can you give me can you just let me test it too? And then I can just show the slides, Bev, so you don't have to worry about it.
Okay. Are you having trouble, Oscar?
No problem. It's okay.
Okay.
I'm not seeing yet the share option here.
Yeah. So Daniel needs to test that, and then me.
Okay. Daniel, let me make you the presenter here. Okay.
Daniel, I think they have to allow you to.
Oh,
do it.
okay, now, okay, yeah. Presenting controls, that's it. Let me see. Turn off, share your screen. Perfect. Okay. Can you see that?
That's coming.
Yes.
Now we can. Yep.
Yes, we can see the
Okay.
presentation.
Thank you.
Okay, and Taylor. I just gave it to you.
I don't want to share that one. So how do I choose the window when I do it?
That's the option of full screen. Well, in this case, everything that is going to be shown in your own screen, it will be shown as a presentation, as a share screen option.
I try to just do. I'm the only one who can't do it, so that's good. We tested it.
Oh, sure, no problem.
I try to do just the screen that I wanted, but I wasn't able to do it.
Oh, okay. You can also try with the window option as an alternative option, just to share the specific window of the application that you want to share, and that will just show the current application.
Yeah, I got you.
Exactly.
Now you can see it.
Perfect. Yep.
All right, then I can make it
see
big
your
on
presentation.
that window. Yeah. I guess I can leave it up, Ev, unless someone needs to share it or try it out in between there, or I can.
No, I think everybody who is sharing has tested theirs, so you can leave yours up. Can you put it in the presentation mode?
Okay.
Buenas tardes, Oscar. Usted comienza, ¿verdad?
So when I try to do that, it gets big on my screen, Bev, but it's not changing on yours.
All right, this is fine.
No, I mean, I'd like to. What am I doing wrong? Because if I hit slideshow, it gets big on mine. Like I'm just doing it in my window, not in here.
Carl?
See, now it's big on mine. But it's not changing for you.
Vernon, can you help?
I'm messaging Pedro right now.
Yes, I'm running here.
All right. So, Ms. Taylor, what's the issue?
So when I click on this to make it full screen, I get a full screen on mine, but you're not seeing it different.
Oh, okay. You can try this. You can cancel the share screen option on the Boost Events platform, and then you can select in your presentation now the full screen option. So by clicking Alt and Tab, you will be switching to the Boost Events platform once again. And once again, you can try to share your screen. And once you select the window option, you will see now the option of the presentation, but now as an independent window option that says presentation full screen. And that will show the full screen option as well. But if you wanted to avoid that, I can also
How about now?
Oh, perfect. Yep.
Yep, that's perfect.
All right. So technologically challenged.
Well, we're using a new platform, so that makes it a challenge as well.
Yeah, technology is not my thing.
So everybody, when we're doing the introductions, Dr. Rodriguez does their introductions. I'm going to take you all off the screen. And then when I'm going to leave Eduardo on as the moderator as well. And then he will introduce the first speaker, Oscar. I'll bring you back on the screen. And then when Oscar is done, I'll bring Hernan Sophia, Omel, and Bernardo back on so you can do your panel, just so there's not so many faces on the screen at one time. But you'll still be able to hear it. You'll just be on the other side of the broadcast, if that makes sense to everybody. But I'll make sure everybody is where they need to be when they need to be there.
Okay. One question, please, Beverly. So 3 talks, 15 minutes each talk, and 5 minutes for discussion for each talk. Is that correct?
That's correct.
Okay. And that will be in 90 minutes. So
that's correct.
Right. So I understand that you can choose the language you want to hear or listen the talks, and but the first talk of Dr. Paredes will be in Spanish. That is now I can do whatever, no, or in English or Spanish.
Whatever you're more comfortable with, you can present however, either in English or Spanish, and then us listening can choose the language we want to hear it in. So if you're more comfortable doing it in Spanish, please do so.
Okay, so I will do that. I'll change to Spanish whenever our discussion here will change. So I'll be in order to listen.
That's correct. But if you're, whatever language you're speaking in, you don't have to change anything on there. It's just the language you want to hear.
Yeah.
Right.
You can speak either. Yeah.
Yeah. Hello, everyone. I want to say some recommendations that we learn after our webinars. César y Oscar, yo creo que es muy importante explicar cómo funciona la plataforma desde el principio cuando empiecen a entrar las personas. Entonces hay que explicarles que en el botón de abajo pueden cambiar la traducción a donde como quieran escucharlo, porque yo me imagino que la gran mayoría de las personas que van a entrar son de habla hispana, entonces seguramente tendrán o querrán la traducción al español. Eso es muy importante que lo digan en español para que las personas que solo hablan español lo entiendan. Y lo segundo es que en la parte de arriba, en la derecha, tienen un chat donde pueden hacer las preguntas y que esas preguntas nosotros las canalizamos a través de los moderadores para las presentaciones. Esa es como la recomendación más importante para que no tengan problemas en las personas que no manejan la plataforma.
Una pregunta, Oscar.
Sí.
Usted hace la presentación los primeros 15 minutos, ¿verdad? El tema sobre la estadística y el tema de cáncer gástrico, y después quedan 5 minutos para el resto del panel, para dar forma, ¿no es cierto? Ya.
Sí, doctor.
Pero la presentación la hace usted enteramente, para no demorarnos mucho. Bien.
Okay.
Sí, y después de la presentación del doctor Paredes, yo pediré la opinión de los participantes como en la discusión o algún tema que ustedes quieran tocar sobre el tema. Y así lo haremos en las 2 siguientes presentaciones. So Beverly, shall I present them to
we're at almost 7 o'clock.
Can I present them? Where are they from when the discussion is going to be? Or
yeah.
How is the protocol?
So Dr. Leal and Dr. Rodriguez are going to do quick introductions. Welcome everybody.
Hola,
and they'll turn it over
Buenas
to
noches.
you, and then you can introduce the first speaker and then whoever's on their panel.
Okay,
Bueno.
right.
Hola, buenas noches.
César, ¿cómo está?
¿Se me escucha bien, no?
Sí, perfecto.
Buenas noches con todos. Vamos a empezar dentro de breves
Is
segundos.
everybody ready to start? We're at about 7.
Okay, hello everybody. Miss Taylor Real, President of the Society for Surgery of the Alimentary Tract. In the condition of the President of the Peruvian chapter, I am very happy to introduce Dr. Eduardo Payet, a member of the Department of the Surgical Oncology, Abdominal Surgical Oncology of the Instituto de Enfermedades Neoplásicas. He will be the moderator in the Early Gastric Cancer in the Americas, a colloquium on current situation and management strategies. Dr. Payet, I am very happy because you was my professor. Please start the session.
Ok. Muy buenas noches con todos. Esta presentación tiene 3 conferencias que durará cada una 15 minutos y tendremos después de cada participante la discusión que tomará 5 minutos en ella. Quiero presentar al doctor Oscar Paredes, que es cirujano oncólogo de abdomen del Instituto Nacional de Enfermedades Neoplásicas acá en Lima, quien nos presentará el estado actual del cáncer gástrico precoz o temprano en el Perú. Doctor Paredes, 15 minutos. Adelante.
Buenas noches con todos. No tengo al momento el botón para poder hacer compartir pantalla. ¿Sí? ¿Pueden ver mi pantalla? ¿Sí?
Ya.
Sí, adelante.
Ok, buenas noches con todos. Muchas gracias por la invitación a la sociedad. Hoy día voy a poder realizar una presentación sobre la situación actual del cáncer gástrico temprano en el Perú. Bueno, como introducción, el cáncer gástrico actualmente ocupa el 3er lugar en incidencia y asimismo es la primera causa de muerte por cáncer en nuestro país. En la mayoría de casos, como conocemos, son diagnosticados en casos avanzados y eso conlleva en nuestra realidad a una alta tasa de mortalidad. Y bueno, como definición, el cáncer gástrico temprano es aquel carcinoma que compromete hasta la submucosa independientemente de su compromiso ganglionar. Estos son cuadros de Globocan del año 2022. Como podemos ver, en sexo masculino el cáncer gástrico ocupa el 2º lugar en incidencia, en sexo femenino el 3er lugar y en ambos sexos ocupa el 3er lugar de incidencia con un porcentaje de 8.8%. Sin embargo, la tasa en lo que corresponde a la mortalidad corresponde al 13.3%, siendo la primera en nuestro país. Asimismo, como podemos ver en este gráfico, tanto en la población masculina como femenina del cáncer de estómago, la incidencia es comparable con los países con mayor incidencia a nivel mundial, como Corea del Sur, Japón y China, como la mayoría de países asiáticos. En nuestro país tenemos data poblacional. La data que nos ayuda bastante en nuestro país es la data que fue recogida en el registro de cáncer de Lima Metropolitana del año 2013 al año 2015. En este libro podemos ver que estómago, el cáncer gástrico, ocupa igualmente el 2º lugar de incidencia en hombres y el 3º en mujeres, y es la primera causa de mortalidad uniendo ambos sexos en nuestro país. Estos son datos del Departamento de Estadística de nuestro instituto, el Instituto Nacional de Enfermedades Neoplásicas, donde podemos ver que del año 2000 a 2021 hemos tenido 16.959 casos de cáncer de estómago. La mayoría de ellos fueron en la capital, en Lima, 8.077, y seguido de Ancash, Junín y Cajamarca. La mayoría fueron pacientes varones. Y como vemos, el estadio clínico 1, que es la data que nos arroja nuestra institución, fue tan solo de 2.2%. Asimismo, podemos ver que los casos nuevos de cáncer gástrico pues se han mantenido del año 2000 desde 561 casos al año 2019 en 823. Aproximadamente de estos casos, en el instituto podemos operar con intención curativa aproximadamente 180 pacientes al año. Bueno, esta tabla es del estudio del doctor Morgan, que demuestra que Perú en el sexo femenino tiene una incidencia tan alta como los países ya mencionados, pero lamentablemente la mortalidad es una de las mayores del mundo. Entonces, en sí, cáncer gástrico precoz fue definido por el doctor Murakami en el 71. La tasa de sobrevida esperada de esta patología es mayor al 90%, siendo la metástasis linfática tiene valores variables a nivel mundial. Definitivamente los valores de Occidente y Oriente son distintos, pero está en un rango entre 8 a 25%. Y esto nos permite que el manejo de esta patología puede ser tanto un tratamiento endoscópico, ya sea escisión submucosa, por ejemplo, o tratamiento quirúrgico, que en sí es la gastrectomía radical, ya sea subtotal o preservadora de píloro. Entonces, ¿qué datos tenemos en nuestro país? En el año 1950 al año 1999 se evaluaron 2.034 pacientes con carcinoma resecado. Estos datos son del libro de cáncer gástrico, primera edición, publicado por el doctor Eloy Ruiz el año 2010 y por Concitec, donde podemos ver que en la década del 50 tan solo representaba el 3% de los pacientes operados. Posteriormente estos datos se mantuvieron hasta la década del 80, donde ya el porcentaje fue subiendo hasta 11 y 12% respectivamente. Pero no tan solo el instituto ha podido dar aportes a la literatura en nuestro país, también tenemos este estudio bastante conocido por el doctor Espejo Romero del Hospital Revaliati del año 2005. En este estudio se evaluaron 371 lesiones de 340 pacientes. Es un estudio descriptivo retrospectivo que evaluó pacientes del año 63 al 2002. La principal localización fue el antro y el diámetro promedio fue de 25 milímetros. La principal histología fue tumores diferenciados. La gran mayoría de ellos, el 55%, tuvieron infiltración hasta la mucosa T1A y el porcentaje de metástasis linfática estuvo alrededor de 12.3%. Asimismo, en la misma institución del Hospital Revaliati, se publicó un artículo del doctor Michel Portanova del año 2010 que estudió 76 casos de cáncer gástrico precoz del año 2004 al 2008. Estos casos representaron el 13% de todos los pacientes diagnosticados. De ellos, 48 fueron lesiones submucosas y el tipo macroscópico más frecuente fue el tipo 1, que correspondió al 30%. Asimismo, el tipo histológico fue el más frecuente y la ulceración, el componente ulcerativo, se evidenció en un porcentaje de 50%. Posteriormente, en el año 2009, el doctor Eloy Ruiz asimismo presenta en la institución un estudio en el cual se estudia 801 pacientes con cáncer gástrico operados con linfadenectomía de 2. En dicho estudio, el doctor Ruiz evidencia que 106 casos fueron pacientes con la infiltración T1 y la mayoría de ellos, 83%, fueron N negativo, no tuvieron metástasis linfática. Posteriormente, 14.2 N1, 0.9 tuvieron N2 y 1.9 N3. La sobrevida de estos casos, el estadio clínico 1A tuvo una sobrevida de 5 años de 85.8% y 1B de 79.4% respectivamente. Asimismo, un aporte importante a la literatura de nuestro país fue el estudio del doctor Eduardo Payet. En dicho estudio se evaluó 420 casos de cáncer gástrico precoz, en el cual, como podemos ver, 183 pacientes presentaron lesiones a nivel de la mucosa y 237 en la submucosa. Tan solo 3 pacientes de los 183 pacientes con infiltración mucosa tuvieron metástasis linfática. Y asimismo, los pacientes que tuvieron infiltración hasta la submucosa tuvieron metástasis linfática un porcentaje del 19% N1, 6.8 N2 y 0.7% N3. En un total de pacientes de 420, 355 no tuvieron metástasis linfática. Con ello nos lleva a un porcentaje de N positivo de 15.5%, que es comparable con los resultados previos mostrados por los estudios ya mencionados. Asimismo, en dicho estudio se evalúa en un análisis univariado los factores que pueden estar comprometidos o correspondientes a la metástasis linfática. De los 65 pacientes que tuvieron metástasis linfática, lo que podemos observar y que fue estadísticamente significativo fue la invasión, ya sea a la mucosa o submucosa. 26.6% tuvieron metástasis linfática en los pacientes con infiltración submucosa, comparado con tan solo 1.6% de los pacientes con infiltración de la mucosa. Asimismo, el tamaño tumoral con un punto de corte de 2 centímetros, los pacientes con tumores mayores de 2 centímetros presentaron un 20.2% de metástasis linfática versus tan solo 7.2% en tumores menores de 2 centímetros. Dado estos aportes a la literatura, en el Departamento de Abdomen del Instituto Nacional de Enfermedades Neoplásicas, llevamos a cabo un estudio el año 2023, en el cual realizamos una revisión retrospectiva, fue un estudio de cohorte retrospectivo con las guías STROBE, y evaluamos todos los casos con cáncer gástrico precoz del año 90 al año 2019, de todos los pacientes operados con gastrectomía radical, ya sea de 1 o de 2, con intención curativa. En este estudio no ingresaron ningún paciente con cirugía paliativa. Nuestros criterios de inclusión fueron una edad mayor a 18 años, un diagnóstico pre y postoperatorio de cáncer precoz, operados de gastrectomía radical, ya sea linfadenectomía de 1 o de 2, con cirugía electiva R0, pudo haber sido abordaje laparoscópico abierto, y como mencioné previamente, pues en caso que sea GIST, NET, linfoma, fueron no admitidos para el estudio, así como cirugía paliativa o de emergencia. Bueno, entonces en estos 30 años que estudiamos los pacientes con cáncer gástrico, tuvimos 4.394 cirugías por cáncer de estómago en este periodo, y de ellos tan solo 501 pacientes tuvieron un diagnóstico de cáncer gástrico precoz. Y de estos 501 pacientes, tan solo 96, que corresponde al 19.2%, presentaron metástasis linfática. Esta es una foto del último paciente que operamos, junto con el doctor Sánchez Bartra, con una gastrectomía laparoscópica. Y en este estudio, como podemos observar, las variables que tuvieron un impacto significativo correspondiente a la presencia de metástasis linfática fueron aquellos tumores que tuvieron un tamaño mayor a 3 centímetros, 63 pacientes de 219 presentaron metástasis linfática cuando tuvieron un tamaño menor a 3 centímetros. Asimismo, el grado de diferenciación también fue estadísticamente significativo, mayor para tumores indiferenciados. La ulceración, ya sea diagnosticada en la patología como macroscópicamente, también tuvo un impacto en la posibilidad de metástasis linfática. 33 pacientes de 105, correspondiendo al 31%. Y asimismo, el grado de infiltración, en este caso hasta la submucosa, 83 pacientes de 279, que fue el 30%, presentó metástasis linfática. Asimismo, la invasión linfovascular y la invasión perineural fueron los dos factores que también tienen un valor significativo para la presencia de metástasis linfática. De toda nuestra casuística, la mayoría de pacientes fueron tratados con gastrectomía distal, 397 pacientes, o gastrectomía subtotal. La gran mayoría de ellos, dado el largo tiempo de estudio, fueron pacientes con cirugía, con abordaje abierto, 96%, y 93% de todos los pacientes fueron tratados con D2, que es el tratamiento quirúrgico estándar de nuestra institución. Al momento de realizar un análisis univariado, podemos observar que sí, los pacientes con tumores mayores de 3 centímetros tuvieron un odds ratio de 3 y un p-valor de menos de 0.01. Asimismo, los pacientes con tumores indiferenciados tuvieron una posibilidad de 1.7 veces mayor de presentar metástasis linfática. La presencia de ulceración, asimismo, fue un valor significativo. El grado de infiltración submucoso, la presencia de invasión linfovascular y la presencia de invasión perineural. Cuando realizamos el análisis multivariado de estas 6 variables ya mencionadas previamente, lo que encontramos fue que los tumores con un diámetro mayor a 3 centímetros mantuvo un valor estadísticamente significativo. Asimismo, la invasión submucosa con un mayor porcentaje de posibilidad de metástasis linfática de riesgo de 2.56, y el factor que más tuvo chance de posibilidad de metástasis linfática fue la invasión linfovascular, 40.8 veces mayor posibilidad de metástasis linfática. Sin embargo, como conocemos, la posibilidad de poder evidenciar invasión linfovascular y perineural previo a la resección es difícil, ¿no? Que es lo que ya hemos podido poner en nuestro estudio. Entonces, lo que nosotros realizamos es, en este gráfico, hemos podido dividir los pacientes y lo comparamos con la guía japonesa de cáncer de estómago que conocemos. Esa guía ha ido variando con el transcurso de los años, pero como vemos, las indicaciones iniciales que fueron dadas por el doctor Gotoda en la década del 90 Como vemos de los 46 pacientes que tuvimos con pacientes con una infiltración hasta la mucosa, no ulcerados y con un diámetro menor a 2 centímetros y diferenciados, tan solo ninguno presentó metástasis linfática. Asimismo, los pacientes con las mismas características, pero mayores de 2 centímetros, tan solo un paciente presentó metástasis linfática, que corresponde al 1.5% de los pacientes. Las dos tablas que están en color azul representan las indicaciones que ahora son absolutas en la guía japonesa, y asimismo los pacientes con ulceración, con infiltración de la mucosa, con tamaño menor o igual a 3 centímetros y diferenciados, 18% de estos pacientes presentaron metástasis linfática, que actualmente son pacientes que son tributarios y se puede tratar con resección endoscópica. Algo que nos sorprendió mucho en nuestro estudio fue que los pacientes con tumores indiferenciados menores de 2 centímetros, sin ulceración y con infiltración hasta la mucosa, ninguno de ellos tuvo metástasis linfática. Y estos resultados también han sido evidenciados en estudios en Brasil, por ejemplo. 2 estudios de Brasil que también presentaron resultados similares. Entonces, este estudio que realizamos el año pasado, llevamos a 3 conclusiones importantes, que en nuestro medio, como conocemos los países de Occidente, pues difiere la patología con los países de Oriente. Los pacientes con un tamaño tumoral mayor a 3 centímetros, con infiltración submucosa, invasión linfovascular y perineural, estos factores son predictores de metástasis linfática en cáncer gástrico precoz. Asimismo, la resección endoscópica es seguro para tumores mucosos diferenciados independientemente del tamaño tumoral, pero no deben tener ulceración. Y un resultado alentador es que los pacientes con tumores mucosos indiferenciados menores de 2 centímetros podrían ser resecados en forma endoscópica. Sin embargo, aún requerimos mayores estudios para poder avalar dichos resultados. Muchísimas gracias por su atención.
Así que ahora voy a presentarles a ustedes a la doctora Sofía McKinley del General Massachusetts Hospital en Boston. Muy buenas noches. Igualmente al doctor Hernán Zacoto del Hospital de Cuenca en Ecuador, el Hospital del Río, al doctor Omel Ceballos de Lima, del Hospital Edgardo Rebagliati, y al doctor Bernardo Borraes de la Universidad Tecnológica de Pereira en Colombia. Muy buenas noches con ustedes. Tenemos 5 minutos para discutir esta situación. Cáncer gástrico precoz es una enfermedad diferente al cáncer gástrico que vemos nosotros. Latinoamérica tiene una situación bastante interesante porque predomina el carcinoma diferenciado del cuerpo y del tercio distal del estómago. Pero sabemos que en el mundo occidental, como lo ha mencionado Oscar, Europa, Estados Unidos quizás, ese tipo de cáncer endémico diferenciado asociado a la metaplasia intestinal viene desapareciendo y migrando hacia el tercio superior. Así que mi primera pregunta iría a la doctora McKinley. ¿Ustedes en Boston están viendo cáncer temprano en el tercio superior del estómago? ¿O cuál es el comentario que podría hacer al respecto sobre esta migración de la localización, o es cáncer avanzado?
Yeah, so first of all, thank you so much for including me, and I really commend Dr. Paredes for sharing the local data. It's really important to study your own patients and outcomes. I have to say that for me, early gastric cancer is something that we see only very rarely at Massachusetts General Hospital. I think that we probably get a very self-selected set of patients in the sense that our population tends to be very enriched in patients with locally advanced or metastatic disease who are seeking a center that may have clinical trials or alternative therapies that maybe the community hospitals or non-academic sites don't have. And so for me, early gastric cancer is actually a very rare patient in my practice, often incidentally found for maybe abdominal pain that is actually totally unrelated to the patient's gastric cancer, or it might be in an older patient who's anticoagulated, and so they have anemia and they get an endoscopy. I do think that your comment about the location of gastric cancer in the United States probably is generally true. It tends to be more proximal, so we do need to do more total gastrectomies for gastric cancer than I think in some other countries where gastric cancer is more common. The other thing that I really worry about is the age of gastric cancer patients, like other GI cancers. I'm worried about younger and younger patients, but again, could just be the site that I happen to work at attracts those patients.
Muchas gracias por su comentario. Y quisiera mover al doctor Sacoto. En Ecuador más o menos conocemos sus números también. ¿Es posible hacer una campaña de despiste de la enfermedad en nuestro medio? Y poder detectar, es decir, Oscar ha presentado de que el porcentaje de cáncer precoz de nuestros pacientes que logran llegar a sala de operaciones rara vez excede el 9-10%, pero si consideramos a aquellos pacientes que no operamos, esta frecuencia disminuye. ¿Es posible entonces aconsejar en Latinoamérica campañas de despiste de la enfermedad?
El tema es controvertido. Ecuador, ubicado al norte del Perú, tiene una tasa bastante parecida. El número absoluto de casos infinitamente menor por la población, pero las tasas oscilan más o menos alrededor de 12 o 14% por 100.000 y la tasa de mortalidad más o menos parecida. Igual que en el caso del Perú y creo que es en el resto de Latinoamérica, sin embargo, la tasa de casos avanzados es bastante alta comparada con la de casos tempranos. En Ecuador también es menor al 10% el porcentaje de casos de cáncer gástrico temprano y justamente por problemas económicos, por falta de acceso a salud y otros elementos más. El Ecuador tiene dos sistemas de salud, un privado y un público, y un instituto que se hace cargo de la mayoría de casos de cáncer en el país, con algo de ayuda gubernamental. Sin embargo, alguno que otro intento por hacer tamizaje no ha tenido el fruto esperado como en el Asia, por ejemplo. De tal forma que de alguna manera se ha venido disminuyendo muy poquito desde el año 1985 la tasa de casos de cáncer gástrico hasta estacionarse al inicio del año 2000, por mejoras en los elementos higiénicos y también por la disminución en la prevalencia del helicobacter, probablemente. Sin embargo, tamizaje o procesos de tamizaje en el país, muy pocos en realidad. Es razón por la cual seguimos operando casos avanzados en la mayoría de los casos.
Gracias, doctor. Doctor Ceballos, sí, usted trabaja en un hospital general, nosotros estamos en un instituto de cáncer. Ustedes ven una población, nuestros números no corresponden a una serie de despistaje de la enfermedad. Son pacientes que son referidos y sí es cáncer avanzado la regla. Pero ustedes como hospital general, ¿qué conducta están tomando para tratar de disminuir la gran frecuencia de cáncer avanzado?
Buenas noches, gracias. Tengo un problema con la cámara. Sí, efectivamente, nosotros somos un hospital de referencia de la Seguridad Social acá en Perú. Y el problema es que nos vienen pacientes de todo el ámbito nacional, ¿no? Entonces, ya nos llegan siempre cánceres muy avanzados. Poner políticas para mejorar nuestro diagnóstico, para captar cada vez más cánceres tempranos, creo que es un poco difícil, ya que tenemos zonas de mucho cáncer como es la selva, donde el paciente en la selva le toma mucho tiempo ir al hospital, a que lo vean, a que lo atiendan, y en la Seguridad Social todos sabemos, creo que no solamente en nuestro país, sino en muchos países las citas son muy lejanas, Entonces creo que ese es un problema que tenemos y que va a ser siempre un obstáculo para poder mejorar nuestra estadística en cáncer temprano. Últimamente, pero sí tenemos cada vez, hemos visto, y los gastroenterólogos que trabajan con nosotros sí están haciendo quizás un poquito más, quizás ha mejorado un poco a los últimos años, pero igual, eso siempre va a ser nuestro gran problema.
Muchas gracias, doctor. Y de la última pregunta quisiera dársela al doctor Borraez de Colombia. ¿Qué recomendaciones haría usted, estimado doctor, para Latinoamérica? ¿Qué debemos hacer para tratar de mejorar nuestros números y obtener más casos tempranos? Cáncer precoz, que fue descrito por la Sociedad Japonesa Endoscópica en los años 60, y reforzó, identificó esta enfermedad como un cáncer potencialmente curable. Y ¿qué recomendaciones haría usted en este foro? Que muchos de nuestros participantes son latinoamericanos. ¿Qué podemos hacer? ¿Cuál es la recomendación que haría Colombia para el resto de países de Sudamérica para tratar de tener estos mejores números?
Buenas noches para todos. Muchísimas gracias por la invitación a César, a Eduardo, a Oscar. El cáncer gástrico en Colombia es un problema de salud pública. A pesar de que es el quinto cáncer en frecuencia, es la principal causa de muerte por cáncer en nuestro país. Tenemos, a lo largo de la historia, hemos desarrollado muy pocos programas de tamizaje y ese es uno de los inconvenientes. Establecer un programa de tamizaje como se hace en Asia a los 40 o 45 años es difícil por los costos y por el volumen de gastroenterólogos y de endoscopias que se hacen al año. Además de eso, tenemos un problema aún más grande y es que los pacientes asintomáticos en estadios avanzados, en estadios 3 y en estadios 4, pueden llegar entre el 25 y el 10%. Es decir, además de que no tenemos una adecuada política de tamizaje, pues tenemos problemas en detectar a los pacientes que que tienen estadios avanzados porque son en algunos casos asintomáticos. Entonces lo que hemos hecho, lo que hemos intentado hacer es detección temprana, incrementar el número de pacientes a los que se les hace endoscopias a edades tempranas, detectar el Helicobacter pylori y lesiones malignas y tratarlas tempranamente y hacer seguimiento dependiendo del tratamiento de las lesiones. Y eso es a lo que se debe encaminar América Latina y hacer costo efectivo ese tamizaje para disminuir el riesgo de desarrollar cáncer gástrico y tener una detección más temprana de lesiones tempranas, valga la redundancia, y así poder curar realmente el cáncer gástrico. El 10% de nuestros pacientes es cáncer temprano. El 90% de nuestros pacientes es cáncer avanzado y esos son los que generalmente van a cirugía con o resecciones multiviscerales o gastrectomías con extensiones de las disecciones.
Muchas gracias, doctor. Perfecto. Vamos a pasar a la segunda conferencia y vamos a movernos ya el doctor Paredes introdujo el concepto de que algunos de nuestros pacientes con cáncer precoz podrían ser sometidos a excisiones más conservadoras. Así que quiero dejar con ustedes al doctor Ulises, al doctor José Sors, ¿verdad? José Sors, que es de Sao Paulo, Brasil, y para tratar de hablarnos sobre qué pacientes podrían ser tratados con resecciones submucosas o tratamientos endoscópicos y qué pacientes deberían ser sometidos a gastrectomías radicales. Adelante.
So, good evening, everyone. Thank you, Dr. Payet. Thank you, Dr. Rial, Dr. Ulysses, and all the Peru chapter for the invitation here. My name is Daniel Shore. I'm just a second. I'm listening I'm listening to my presentation. I don't think I want that. The translation. Okay, I stopped here. Okay. So I'm going to present this interesting topic regarding early gastric cancer, who should undergo endoscopic or surgical management. So this is our complex. This is the Cancer Institute of the state of São Paulo. So for definitions, gastric cancer, major cause of cancer-related deaths worldwide, recent decline due to spread of H. pylori eradication. Early detection is keystone for better prognosis, and that allows us for less invasive treatment options as endoscopic resections. So gastric cancer is the fifth most common cancer worldwide. Oscar has already talked about that. Latin America has a high incidence, and Peru is the has the highest incidence in Latin America regarding gastric cancer. As a matter of comparison, in Brazil we have almost 14,000 new cases per year. In Peru, almost 70,000 new cases per year. So definitions of early gastric cancer. So it's an adenocarcinoma confined to the mucosa or submucosa, regardless of lymph node metastasis. And this lymph node metastasis occurs from 2 to 20% of patients, and it's related to a better overall survival and prognosis. But early gastric cancer, it's a complex disease. As we are going to see further in these presentations, we have different presentations, characteristics of the lesion. So it's a complex disease in a potentially complex patients regarding age, comorbidities, heart disease, pulmonary disease, medications. So we have to pay close attention to early gastric cancer. We would like that the diagnosis and incidence of gastric cancer would be higher. In Western nations, 20% of those cases, more or less. In Asia, due to screening programs, almost 50%. In Brazil, from resected patients, we have almost 30% of the lesions as early gastric cancer in those who underwent surgery. And why the presentation of early gastric cancer is more common in Japan and South Korea as well is due to the surveillance programs, biannual endoscopic screening for population over 50 years old with a target of 50% of the population. United States does not have a national screening program due to low gastric cancer, and it's reserved for patients with high risk populations as immigrants or family history of gastric cancer. In Brazil as well, we don't have a national surveillance for gastric cancer mainly due to costs for the whole population. So what is the current data and treatment for early gastric cancer? So the Japanese guidelines here, we are seeing the whole treatment for both early and advanced gastric cancer, and you should focus on the early gastric cancer. So we can see that we have options for endoscopic resection and gastrectomy surgical resection. The surgical management should include the gastrectomy with lymphadenectomy, D1 or D1 plus, and the endoscopic resections, whether being mucosal resections or submucosal dissections. The advantages are clear. They are less invasive approach with good quality of life and outcomes. But one should note that the patient must have very low possibility of lymph node metastasis, and the lesion itself should be suitable for unblocked resection. And now we face a therapeutic dilemma, whether to make a functional preservation or an oncological control. So if you want endoscopic resection and preserve stomach function and quality of life, we must trade off that characteristic with the risk of lymph node metastasis. And on the other hand, if we perform a more aggressive surgical treatment, we reduce the oncological risks, but we compromise quality of life. And we always have to take into consideration age, functional status, and comorbidities. And the central question is how to balance functionality, quality of life, and oncological safety, always keeping in mind that it's essential to understand the risk of lymph node involvement. So the criteria for endoscopic resections are, as we all know, are absolute, expanded, and relative. We are going to spend a couple of moments here. So to decide whether to perform an absolute or expanded criteria, we should take into account if the adenocarcinoma is differentiated or undifferentiated, has or not ulceration, is in mucosa or submucosa, and the diameter of the lesion. So if the lesion is differentiated less than 2 centimeters with no ulceration in the mucosa, this is the perfect fit for absolute for endoscopic resections with a low incidence, very low incidence of lymph node metastases. As we expand, we can see that patients with differentiated lesions with no ulceration, more than 2 centimeters, or differentiated lesions with ulceration less than 3 centimeters from the mucosa. And also, if it reaches the SM1, meaning that it reaches up to 0.5 millimeters inside the submucosa with a diameter less than 3 centimeters, or the lesion is undifferentiated with no ulceration, those kind of lesions are suitable for expanded criteria to endoscopic resections with a slightly higher risk for lymph node metastasis. All other cases require surgical resections, and we must keep a close attention here to the undifferentiated lesions that almost all of them require surgical resection. And Oscar have already demonstrated this chart as well. So the incidence of lymph node metastasis, we should pay close attention here. If the lesion is undifferentiated and invades the submucosa, the risk of lymph node metastasis can get up to almost 20% of those cases. So the undifferentiated lesion is a very tricky and requires close attention. The other indication is a relative indications when the patient has indication for a gastrectomy, but due to some clinical circumstances as comorbidities, old age, this patient is going to is going to receive a less invasive technique as the ESD, for example. So how are we treating early gastric cancer around the world nowadays? So data from the United States, this is from 2017. Patients divided into absolute or expanded criteria. And as we can see, patients with absolute criteria underwent endoscopic resections in 26% of the cases. As we expand, endoscopic resections for 18% of those patients fit to expanded criteria of endoscopic resection. And we can perceive a trend for the last decade to increase in the endoscopic resection and less indications for surgery. And this trend is more for those cases meeting absolute criteria for endoscopic resections. So data from our center here in São Paulo, we have early gastric cancer in these casuistics in 28% of those cases, and only 5% of the whole casuistics underwent endoscopic resections, meaning that 30% of patients with early gastric cancer were treated with endoscopic resection. Last September, the Japanese group published this review of 100,000 gastric tumor resections per year, and the rates of endoscopic resection over there is 57% from 2021, and a decrease in the indications for total gastrectomies. As we can see here, the blue bars are the indications for our patients who underwent gastrectomies, and it gets lower as patients get older. And this line, the black line here, demonstrates the endoscopical resections. So as patients get older, they receive more endoscopical treatments. So what is the potential risk of lymph node metastases in patients undergoing endoscopic resections? So also data from our center here. These casuistics demonstrated early gastric cancer in surgical resected patients, 22% of those cases, with lymph node metastases in 13%, 10% for mucosal invasion, and 15% in submucosal invasion. And when we put those patients, resected patients, in the criteria for endoscopical resections, those who met absolute criteria didn't have lymph node metastasis. So we are meaning here differentiated adenocarcinoma, less than 2 centimeters, no lymphatic invasions. But when we expanded the criteria, if the patient had an undifferentiated adenocarcinoma, the rates of lymph node metastasis can get up almost 30%. So again, we have to pay close attention to those undifferentiated lesions. As well, if the depth of invasions reaches the submucosa, 13% of our casuistics has had lymph node metastasis. So how to interpret the results of endoscopic resections and the possibility of cure? So from the Japanese guidelines, we introduce here the E-cure, endoscopic curability, A, B, and C. So after the patient received the endoscopic resection, if the lesion was from a differentiated type, no ulceration. Differentiated type with ulceration and the lesion less than 3 centimeters, and undifferentiated type, no ulceration less than 2 centimeters, this lesion is a E-cure A. If the lesion invades the submucosa up to 0.5 millimeters and is differentiated type less than 3 centimeters, it's an E-cure B. And all other cases are E-cure C2. Okay, and the E-cure C1 refers to the differentiated resections with positive horizontal margins or piecemeal resections. So what do you have to do after these endoscopic resections, and who is going to necessitate surgery after all? So we are going to focus here first in the differentiated type. So the patient received endoscopic resections. If the lesion is T1A, no ulceration, T1A with ulceration less than 3 centimeters, or T1B less than 3 centimeters with negative horizontal margins, this patient is E-cure A or B. And for the E-cure A and B, the idea is to have a long-term follow-up for sure, due to also metachronic disease inside the gastric mucosa. But for E-cure A, annual EGD, and E-cure B, annual EGD plus an image being ultrasound or CT scans. If this patient have a positive horizontal margin, there are different alternatives for treatments, being another endoscopic resection or surgery, direct surgery. And if the patient does not have any of those events, it's an E-cure C2, and these patients needs a salvage surgery in order to address the lymph node stations and to perform the gastrectomy. And talking about the undifferentiated type, if the lesion is intramucosal, no ulceration, less than 2 centimeters, negative horizontal margins, vertical margins, and no lymphatic invasion, this is an E-cure A, and this patient is going to be followed up with annual EGD for long term. And if it's not, it's an E-cure C2, and we have to perform surgery for this patient. So data from this year from our center, 160 patients with early gastric cancer who underwent gastrectomies. So we divided them into the criteria for E-cure A, E-cure B, and E-cure C. And the lymph node metastasis group was 5% in E-cure A, 18% E-cure B, and 19% in E-cure C. So in our reality, we demonstrated that the E-cure B group has a high incidence of lymph node metastases, and that caught our attention, and for sure we are going to see what happens to these patients during follow-up and what is going to be their evolution and prognosis. So I think this is important for every country and center to have their own idea of what is the lymph node involvement according to each ICURA after the resected specimens are analyzed. So the take-home messages for sure, early detection is critical for the possibility of less invasive techniques. The treatment are endoscopic resections and surgical management. We must balance quality of life and oncological safety. We have to pay close attention to the undifferentiated lesions, and we have to know the incidence of lymph node metastases in the cohort of patients from your own center according to the ICURA criteria. Thank you very much. I don't think you are listening.
¿Qué? ¿Perdón?
Okay.
¿Sí me escuchan? Sí.
Yes.
Right. Sí. Así que quisiera preguntarle al doctor Bernardo, se han introducido entonces 3 conceptos o 3 posibilidades de tratamiento para nuestros pacientes con cáncer gástrico, y dependerá de la exactitud de nuestros gastroenterólogos y de nosotros mismos como cirujanos hacer correlaciones clínico-patológicas y poder decir cuál es el nivel de infiltración del tumor a través de la pared gástrica y qué clasificación usar, si estos son elevadas o deprimidas. Pero, y dentro de estas 3 posibilidades tenemos pues las excisiones submucosas, uno, la cirugía radical por otro lado, y las cirugías funcionales. ¿Cuál es la exactitud de ustedes en Colombia o en su institución? Porque hacer una experiencia nacional probablemente tenemos que basarnos en la experiencia de centros de referencia como los institutos que están presentando sus números. Así que, ¿qué recomendación haría usted si estos pacientes no pueden ser referidos a grandes instituciones nacionales de cáncer? En Corea el 90% de sus casos son cánceres gástricos tempranos y ya la cirugía radical está desapareciendo. Adelante, Bernardo, ¿qué podría decir al respecto?
Es al contrario, el 90% de nuestros tumores son avanzados. Lo que sí es muy importante es definir adecuadamente la estadificación. Nosotros generalmente utilizamos un tag de tórax y un tag de abdomen para hacer la estadificación inicial, y ante la presencia de tumores tempranos hacemos ultrasonografía endoscópica para determinar si realmente son tumores tempranos. Ciertamente, preservar el órgano es nuestra prioridad. Entonces, en medida que esos pacientes clasifiquen con las indicaciones que dio Daniel, que utilizamos exactamente las mismas para poder realizar una disección endoscópica, procedemos a una disección endoscópica. Yo creo que en esta época es muy importante remitir los pacientes al lugar indicado o al sitio indicado, a la persona que tenga más experiencia para realizar el procedimiento. Y esa es la importancia de tener grupos multidisciplinarios donde los endoscopistas hagan disecciones endoscópicas de la mucosa o de la submucosa, y en medida en que los pacientes puedan evitar una cirugía y preservar el órgano es lo ideal. Ese es nuestro objetivo, por lo menos en estos momentos en que estamos.
Y Bernardo, una repregunta.
Sí, señor.
¿Recomendaría estas excisiones submucosas en pacientes que son fuera de la región y que tiene posibilidades de que se pierdan de vista?
Yo creo que con una,
Que no
con
le
una
puedas...
adecuada... ¿Me repite, perdón, la última? Perdón, adelante.
Sí, ¿qué recomendación haría? Es decir, nosotros como institutos de cáncer en nuestros países, muchas veces vienen pacientes a los cuales no podemos asegurar un seguimiento periódico.
Sí. Yo creo que los pacientes deben ir, vuelvo, repito, hacia el lugar indicado, donde más haya volumen de pacientes, donde se tenga una mayor experiencia. Los pacientes deben ser remitidos para ser tratados adecuadamente y, por supuesto, llevar un adecuado seguimiento. Nosotros tenemos exactamente el mismo problema que usted menciona, y es que a veces el seguimiento es difícil porque los pacientes no son del médico o de la institución, sino de los seguros de salud. Entonces ellos los remiten para seguimientos en otras instituciones. Lo ideal es que se realice el estudio, el manejo y el seguimiento en la misma institución por un grupo multidisciplinario, sí, señor.
Muchas gracias, Bernardo.
Gusto.
Sofía, no estoy seguro de que te están traduciendo al inglés, pero vámonos al tercio superior del estómago y a la región
Yes.
cardial. No vamos a discutir el antiguo Siebert-II, ¿no? Que ya estamos de acuerdo que ya no usamos la clasificación de Siebert, y el adenocarcinoma del esófago es esófago, y cardias y tercio proximal es estómago. Pero, ¿qué hay del cáncer del cardias si uno encuentra una lesión ligeramente deprimida,
Yeah.
no
So
ulcerada, y que es menor de 1 o 2 centímetros?
yeah, that's
¿Recomendarías una excisión submucosa o le harías una gastrectomía?
yeah. So I'll say that was an excellent presentation on early gastric cancer and thinking about endoscopic versus surgical resection. And I want to emphasize how many experts it takes to come to a decision for any individual patient. And so we recently reviewed a case at our tumor board, very similar to the case you just asked me about. And I'll point out that it took a advanced gastroenterologist who was able to do an en bloc resection of what appeared to be a very T1A gastric cancer. And it also required our specialty GI pathologist, and they measured how many microns into the submucosa this tumor went. So it was actually an SM1 tumor. And they were able to comment exactly the diameter, the presence of ulceration, lymphovascular invasion, perineural invasion, horizontal margin, as well as the deep margin. And what I would tell people is for each of these cases of early gastric cancer, it's really important to have all of that pathologic information about the tumor in order to make an informed decision. We are very lucky to have outstanding interventional gastroenterologists who are very aggressive and willing to try to do ESD on tumors in the cardia, esophagus, GE junction. And so I agree with the philosophy of attempting organ preservation, especially in an older patient, which is often the patients in my practice who are found to have gastric cancer. That being said, there are still going to be many patients who fall within acceptable criteria for ESD who will want to pursue surgical resection because of their own preferences about how to be treated. That ECURA C with the positive horizontal margin, there's 4 acceptable treatment options for that category of tumor. And so patient values and shared decision making are really important in early gastric cancer.
Right, Sophia, but again, if it depends of the accuracy of the expertise and in trying to detect the clinically or endoscopically the T. Would you recommend in these patients? I mean, in last ASCO, there's no discussion that the flood regimens must be done in these patients, and after 4 cycles of flood followed by surgery. Are you doing this? Would you recommend that? Or?
For early gastric cancer?
Yes.
No, we don't do FLOT for a T1A type tumor. If a patient has an early gastric cancer and they're not a candidate for endoscopic resection, that patient would go straight to surgery.
Right.
And if it was upstage, then they would get adjuvant systemic therapy.
And in these cases that you will perform surgery, what kind of surgery will you do? Are you familiar? Are you happy with proximal gastrectomies or total gastrectomies?
So I would say that we typically would do a total gastrectomy. We are starting to think about proximal gastrectomy with double track reconstruction. But I would say that the standard pathway for proximal gastric cancer would be a total gastrectomy.
Right. Well, thank you very much. I'll move my language to Spanish. Gracias nuevamente. Creo que estamos con el tiempo, son las 8 de la noche y vamos a ir al último tópico, ¿qué hacer con estos casos de cáncer gástrico precoz? Nos gusta el término precoz más que temprano, en los casos de carcinomas indiferenciados. Hoy día hay una gran confusión sobre qué clasificación histológica utilizar, esta definición de carcinoma cohesivo, de los que se mezcla con los carcinomas de células en anillo de Sey. Y el doctor Ulises Ribeiro va a tocarnos el tema sobre el manejo de cáncer precoz en los carcinomas indiferenciados. Doctor Ribeiro, adelante. Doctor Ulises Ribeiro.
Yeah. Can you hear me? Yes. First, I would like to thank you for the invitation. And I would like to congratulate you, the SSAT, in the name of the Dr. Royal, our president. I congratulate you and I thank you for allowing us to have this Latin American meeting with people from Peru, Colombia, Mexico. We are from Brazil, and it's a pleasure for us to participate. Thank you very much. I think I'm gonna present without the screen, so if there's any problem, you just let me know, okay? I'm gonna talk about some aspects of the undifferentiated early gastric cancer. I have no disclosures. So many of these undifferentiated tumors are aggressive tumors that begins with this behavior. And there are some papers like this one that I'm showing to you that is explained this behavior through molecular alterations. And as you can see, we have 2 clusters of undifferentiated tumors. And there are 40 genes that are differentially expressed between these clusters. And the MYC gene and p53 exhibit an aggressive pattern in signet ring cells and mixed tumors.
Excuse me,
yes?
Ulises, we can't see your slides.
Oh, sorry.
We cannot see your slides, yes.
Can you see now?
No.
No.
Maybe somebody can help him.
Okay, doctor, you can perform another attempt to share your screen, please.
How about now? No?
Ainda não.
Negative. Let me just give you back the floor once again so you can make another attempt right away. Just one moment, please.
I think now will be okay. How about now? No?
Oh, no, you can make another attempt, please. No. Okay, I can see a window that says workspace.
Is that working?
So
Yeah,
está compartilhando
actually,
a
I
tela
can
do
see
Gmail.
like your inbox, your Gmail inbox.
And how about the presentation? No?
No, I cannot see the presentation. I just see like a panel of one of your of your email inbox. If you want to try another attempt, you can just please cancel the share screen presentation, cancel the screen share option, and try once again by sharing the screen once again with the window of the application as well. Otherwise, I can suggest you to please make the whole screen share option so you can share your full screen fully on your presentation.
I don't know what I'm doing wrong.
Can you just please just cancel the screen share option and try once again by sharing your full screen in this case, please? Thank you.
Okay, which one should I choose? Window.
You can select the full screen option.
Full screen option.
Or you can also select the window option and select just the option of your presentation. If it's a PowerPoint. Okay. Okay.
There we go.
I see now the presentation.
Can you see?
Yeah, we can see it.
Okay. I'm sorry about it. As I was telling you, there are some papers or manuscripts showing us that molecular alterations are driving these tumors to be more aggressive. And here I'm having this example, and you can separate two clusters of tumors, one more aggressive than the others. And the most common alterations are SMIC and P53, and less tumor suppressor gene mutations in these tumors, and less microsatellite instability. Otherwise, you have more ICA during hypermethylation and a deficient SMART4 gene. So we know that this begins as a very bad tumor. And here, Daniel has told us in a very good job that we have the risk of lymph node invasion. And this risk is based in a histological type, the size of the lesion, and the presence or not of the ulceration. But the depth of the infiltration is very relevant in this case for the T stage. As you can see, in M3, you in the mucosa and the lamina propria, you can have a lot of lymphatics in these regions, especially the submucosa in the lamina propria of the mucosa, and you start to having lymph nodes. For the submucosal one, or at 500 microns, 8.8%, and after that, at 23% when you choose to SM3. So how can we stage better these patients? We can do endoscopic ultrasound, especially for T stage, with sensibility and specificity around 85 and 90%. And you can do biopsies if some of the lymph nodes are nearby. Here is one example of an elevated lesion, and show us that just is a mucosa tumor. But another way to stage these patients is doing a ESD, or submucosal endoscopic dissection. And here you can see some aspects of this resection. And here is a very large defect, including mucosa and submucosa. As you can see, the musculars of the stomach. And we prefer in block resection like this one, if you do endoscopic resection. So the lymph node metastasis varies from 5.7 to 29%, especially in undifferentiated tumors. As Daniel showed us, if the tumor has no ulceration and less than 20 millimeters, you can still do endoscopic resection, but this patient has been followed closely and has to be analyzed, this specimen, through very nice pathologists, as told us Sophie. For all the others under the undifferentiated tumors, we indicate the surgery, and we have to do a gastrectomy with lymph node dissection. Some aspects of the treatment for in the early gastric cancer is first, I'm going to talk a little bit about the axis, the margins, and the lymphadenectomy that we should do in these patients. The comparison between open and laparoscopic resections comes from a large clinical trial from Asia and China, Korea, and Japan with large number of patients, and they have shown us the short-term results and the survival are similar when we do open or laparoscopic surgery. So after these papers have been published, we change our approach to use laparoscopic resection for early gastric cancer in our center. And here is one paper that we've published. And as you can see, we have 797 curative gastrectomy in the Instituto de Câncer do Estado de São Paulo. And of those, 438 open gastrectomy and 92 gastrectomies, laparoscopic gastrectomies. We did a propensity score matching 1:1, comparing then 92 open gastrectomies with 92 laparoscopic gastrectomies with the same age, sex, stage. And we could find that the number of lymph nodes resected were similar, 37 by the open approach and 42 by the laparoscopic approach. And of T1 and T2 lesions, 185 or 42% for the open approach and 62% for the laparoscopic approach. This first survival graphic show before the propensity score, show us that different curves. But when we do propensity score matching, you can see that both overall survival and disease-free survival are similar. So we could conclude that laparoscopic gastrectomy was a safe and effective method for stage 1 to 3 with short-term comparable results. We are doing a clinical trial using laser fluorescence indocyanine green in gastric cancer patients. First, in robotic surgery and laparoscopic to find the margins of the tumors, because you can inject the solution in the submucosa, you can see clearly where is the tumor. And then we are doing a trial studying the sentinel node. You can see the injection, the submucosa, and you can change the filter of the equipment and find the lymph nodes, and this can be resected and separated. And another important thing, especially in obese patients, is the adequacy of the lymphadenectomy. As you can see in this 6 chain, that this lymph node will be left behind if we haven't used the indocyanine green in this case. What we have published about this topic in the literature, we have this meta-analysis, a systematic review meta-analysis showing that this methodology has high sensitivity and high specificity. And we have this trial, a Senorita trial, that's a Korean trial, and they include 266 patients who had gastrectomy with lymph node dissection, that as we do now, compared to 245 patients who had less aggressive surgery, like a wedded resection or segmental resection or endoscopic procedure plus lymphadenectomy. And they have shown us that the detection rate is around 95% of the sentinel node. And the secondary outcome of this paper is morbidity and mortality at 30 days, and the short-term results are the same. So now I'm going to present a case, and I would like to discuss with you, if we can. Can you see the presentation? Yes? Because if not, I cannot see you. So I'm going to use this. So this is a 74-year-old male. The history is dyspepsia, heartburn, and weight loss of 8 kilograms. And he underwent upper digestive endoscopy in April of 22. And the upper digestive endoscopy show asymmetrical ulcerated lesion, irregular and elevated wedges, measuring 10 millimeters in the anterior wall of the antrum. In the biopsy, showed a poorly differentiated adenocarcinoma, ulcerated. He had an open prostatectomy 12 years ago, was an ex-smoker, hypertension, and asthma. And we no family history. The physical examination was pretty good. ECOG 1, KPS 90, BMI 27.3, and the lab was normal. So we repeat the upper digestive endoscopy in our institution. And here you have the transition and ejection, and we have atrophic gastritis in the body and the antrum. And this lesion can be seen by light endoscopy and chromoendoscopy. And here with indicocarmine showing the lesion. And here again. So I would like to ask you, what do you do with this case? Do you rely on this endoscopic examination only do you think that we should do another kind of exam, or what do you think? Who could start? Oscar, what do you think?
Yes, I think this patient, maybe because, it's an undifferentiated lesion, 1 cm, and also, but this patient have ulceration, so that's why I'm thinking maybe surgery is the best option because of the ulcerations. In our data, we have 26 patients with undifferentiated lesions, and when these patients have tumors less than 2 cm, even these tumors have or not ulcerations, these patients didn't have lymphatic metastasis. So by the time in the Japanese treatment guidelines, the option is surgery. But I think, yes, surgery, or maybe sentinel lymph node. And now this, as you presented the Senorita trial, the PI of this investigation is my professor, Kenwoo Ryu. So by the time, I think that is another very good option for this patient.
Tofi, what is your workup with these patients? Do you PET scan in these patients?
So
how do you proceed after the diagnosis?
Yeah, so let's say we got this patient at our tumor board and all we had so far was the EGD and a biopsy. We would get staging, axial imaging, chest, abdomen, pelvis, and assuming there was no distant metastatic disease, no regional lymphadenopathy, and we could not see the tumor on the CAT scan, this is somebody that we would send for endoscopic ultrasound to get a better sense of the tumor depth. And think about, is this somebody who would get an upfront surgical resection, or is this somebody who needs multimodal therapy? I think with the ulceration, the poorly differentiated tumor, we would, and if this is a functioning person in their 70s, we probably would not be as keen to do any kind of endoscopic resection for this patient, but favor radical resection given the pathology features you've shared so far.
Okay, good. So the biopsy showed a poorly differentiated adenocarcinoma of mixed invasive type with poorly cohesive cells, angiolymphatic evasion present, and other finds complete and incomplete intestinal metaplasia in adjacent gastric mucosa. Helicobacter was negative. So we did CT scans of thorax and abdomen, as you told us. We don't do PET scan. Unfortunately, I cannot open the CT scan, but I'll show the results. So there was a discrete parietal thickening of the gas canton, undetermined, signs of prostatectomy, and absence of abdominal lymph node enlargement or free fluid. So basically, it was just a thickening of the gas canton. Okay. So we did then a subtotal gastrectomy with D2 dissection and Roux-en-Y gastric reconstruction via robotics without any complications. And in the intraoperative findings, absence of serosal involvement, absence of lymph node disease, and or ascites or any fluids. The patients went very well, discharged at 6 day postoperative, and with good diet acceptance, walking, and controlled pain in surgical wound. Here is the specimen. We do separate the chains of the lymphadenectomy every time because it's like a Japanese, when they are getting the train, they're saying the same movement all the time. So it is important for us because when you separate the chain, you know that you did a good job taking out the lymphatics, the lymph nodes that we have to do it. Do you do the same?
We don't have the box, but I've started separating my lymph nodes from my gastric resection specimen because I find our pathologists have a better lymph node count when I separate into multiple packets than if I send in block.
Yes, that's another reason. Here is the specimen, and here's the pathology. So was a Laura mixed type adenocarcinoma and a whole calcification adenocarcinoma of poorly cohesive cells with signing ring variant and rare tubular component. So it's a mixed type. What is the worst prognosis for us? With 0 of 25 lymph nodes. So it was PT1B, PN0. Okay. And here is the pathology. You can see the mucosa in the submucosa and the tumor invading submucosa here, PT1B.
So
Okay.
far, one question, please, Ulises.
Yes, Dr. Eduardo.
Yeah, what was the distance from the you perform a total gastrectomy, you said, right?
No, subtotal.
Sorry?
Subtotal.
Ah, subtotal. Okay. Some schools are following or recommending total gastrectomy for all undifferentiated tumors. So what is your, due to the difficulty of identifying the superior border of the tumor? Sophia, what do you think about that?
Yeah, that's a great question. One of our medical oncologists, actually, that's his sort of personal view that all of these very poorly differentiated, poorly cohesive signet ring cell type tumors may benefit from having a total gastrectomy. I will say that in our institution, we have a very low threshold to do diagnostic laparoscopy on patients with this histologic subtype, even if the tumor is very small. And we will find that there are patients who have SSAT positive cytology, sometimes when you may not expect it. And I would say in particular with this case, if there's any CT abnormality of the stomach wall, that is a patient that I would do a diagnostic laparoscopy on. It's really the patients who have no CT findings whatsoever that we would omit it on. In terms of the proximal margin, what I will do with my robotic cases is I think this is a great use of the ICG, is to use it to, when you do your peritumoral injection, the ICG helps you really identify the tumor and can really help you do a more proximal transection, I think, for these tumor types. So I will try to do more like a 7 or 8 centimeter margin when it's this poorly differentiated tumor, whereas the well to moderately differentiated, comfortable with a shorter proximal margin. I think that's more in line with some of the East Asian guidelines. I don't think you'll find that in our NCCN guidelines, but I think it makes sense. And definitely, I don't know, I'm sure you did this, but the frozen margin assessment, I think, is really important. And our pathologists have actually they get very irritated with me when I bring these specimens to them because it's a very long proximal margin. It's a lot of cassettes that they have to look at, and they also have to mag up to look for these signet ring cells based on this histology. So the pathology resident tells me these are their most hated frozen margin assessments to do, but I think it's really important. It's a good reason to get first case starts for these cases. Yeah, it's justified to get it to the GI pathologist.
Oh, thank you very much. Bernardo, do you have any comments on that?
Operatoria en caso de que tengamos dudas de del margen que podamos conseguir. Lo cierto es que entre mayor margen usted pueda conseguir, mejores resultados seguramente va a tener, sobre todo en los tumores indiferenciados, pero hacemos endoscopia intraoperatoria si es necesaria y si tenemos algunas dudas acerca del margen que necesitamos.
Bueno, yo creo que ha sido sumamente interesante tocar estos tres temas. Creo que debemos insistir en el diagnóstico temprano de nuestros pacientes, en la sospecha clínica de la enfermedad y probablemente en Latinoamérica el amplio uso de la endoscopía. Bueno, hemos cumplido los 90 minutos, César, y así que agradecerles a ustedes por la oportunidad que me han dado de moderar este tema. Creo que está bien como tocar en Latinoamérica y discutir cáncer temprano, cáncer precoz, que es nuestra meta, y insistir en discusiones de este tipo. César, te paso el micrófono.
Gracias. Reuniones latinoamericanas sobre cáncer de estómago hay muy buenas y esta es una de ellas muy buena. Sofía, Ulises, Bernardo, Hernán, Romel, Daniel, muchas gracias por su participación. Doctora Taylor, muchas gracias por permitirnos su compañía para seguir haciendo crecer este capítulo. El mes pasado tuvimos la presencia de 2 miembros de la SSAT en Trujillo, el doctor Vic Velanovic y el doctor Eduardo Montalvo, quienes nos honraron con sus presentaciones. El próximo año pretendemos hacer un congreso presencial en la ciudad de Cusco y pronto les estaremos avisando para que nos acompañen y podamos disfrutar. Lo último, al doctor Payet, mi profesor, mis más grandes saludos, feliz de haberlo conocido, feliz de tener su amistad y muy buenas noches con todos.
Gracias.
Thank you everybody for attending. It was wonderful.
Gracias.
Thank you, Taylor.
Bye, thank you.